All right, let's dive into the new blueprint for the new surgical management of bronchogenic carcinoma. In 2026, we're seeing a really fundamental transformation. So much of what guided us for decades has been rewritten by new biological insights. What we're about to walk through is that new standard of care.
For the longest time, our approach was pretty straightforward: maximal tolerated resection. It was a strategy driven almost purely by anatomical boundaries. Well, the 2026 standard is a complete paradigm shift. We've moved to what we're calling biology-driven precision surgery. Our decisions are now informed not just by where the tumor is, but by what it is, its molecular signature, its biological behavior. So here's our roadmap. We're going to cover the 5 pillars of this evolution. We'll start with this new surgical paradigm, then we'll look at the hard evidence behind sublobar resections. After that, we'll do a deep dive into the critical updates in the 9th edition TNN staging, explore the massive impact of neoadjuvant therapy, and finally, we'll look at the cool tech that makes all this possible.
At its heart, the new philosophy is simple. We are moving way beyond a one-size-fits-all approach. For non-small cell lung cancer, the days of just defaulting to a lobectomy for every resectable tumor, they're over. It's been replaced by a much smarter, personalized surgical plan, one that's tailored precisely to the tumor's biology and, of course, the patient's physiology.
Now, this isn't just a new idea. It's a paradigm built on rock-solid evidence. 2 massive landmark trials, JCOG 0802 and CALGB 140503, really provided the pivotal data that officially challenged lobectomy's long reign as the undisputed king for early-stage lung cancer. So for those small stage IA tumors, the data is just crystal clear. A segmentectomy now gives us comparable 5-year overall and disease-free survival to a full lobectomy. But here's the kicker. The differentiator is the superior preservation of pulmonary function, and that's a huge victory for the patient's long-term quality of life. But, and this is a really important but, this shift is governed by some very strict rules. To keep things oncologically safe, the criteria for doing a segmentectomy are totally non-negotiable. Your margin has to be at least the diameter of the tumor or a bare minimum of 2 centimeters. You absolutely have to do systematic lymph node sampling and frozen sections of your key margins. And critically, if you can't meet any of these criteria, you convert to a lobectomy, no question. Okay, this brings us to what is, honestly, the absolute core of the 2026 updates, the 9th edition of the TNM classification. And that subdivision of N2 disease specifically has completely reshaped how we think about surgical candidacy and prognosis. So think about it like this. The 8th edition just threw all ipsilateral mediastinal nodes into one big bucket called N2. The 9th edition comes along and unmasks the fact that this group is not all the same. It splits it into N2A for single-station involvement and N2B for multi-station. Now, this is not just a semantic change. It defines 2 totally distinct biological entities that go down different treatment paths. N2A, that's now what we consider the surgical N2. And the data just screams at you why this distinction is so important. The 5-year overall survival for single-station N2A disease is sitting around 52%. But for multi-station N2B, it plummets to 38%. That survival gap of nearly 15% is a powerful biological signal that now dictates our entire therapeutic algorithm. You just can't ignore it. Now, inside this new framework, there's this really important prognostic subtype we have to recognize: the skip N2A metastasis. This is when a single N2 station is involved, but there's no N1 hilar node involvement. And get this, these patients have a 5-year overall survival around 72%, which is basically the same as N1 disease. Finding this pattern makes that patient a very high-priority surgical candidate. Okay, so being able to reliably tell an N2A from an N2B before you operate, that requires an absolutely exhaustive staging protocol. This right here is the 2026 standard. You start with your non-invasive selection, then you move to mandatory endosonographic mapping with systematic sampling of at least 3 N2 stations to really hunt for that micrometastatic disease, and finally, if you need it, surgical confirmation with a VAM. So you might be asking yourself, how does this incredibly refined staging actually change what we do before the OR? Well, it changes pretty much everything. It's what has kicked off the neoadjuvant revolution. We are now squarely in the era of neoadjuvant immunotherapy. For that surgical N2, the N2 group, the debate is no longer whether to operate. The question now is how to best prepare that patient for the surgery. We're now giving systemic therapy before resection to downstage tumors, wipe out micrometastases, and dramatically improve long-term outcomes. 2 landmark trials really define our options here. Checkmate 816 using nivolumab takes a pure neoadjuvant, sort of a one-and-done approach, with 3 cycles before surgery. Then you've got Keynote 671 with pembrolizumab, which uses a perioperative Sandweiss protocol, 4 cycles pre-op, followed by a full year of therapy after resection. The different PCR rates really reflect 2 distinct philosophies on how long and when immunotherapy should be given.
And this is the goal, 95%. Let that number sink in for a second. We call this the surgeon's reward. It's the approximate 5-year overall survival for patients who get a pathological complete response after their neoadjuvant therapy. It completely transforms a high-risk disease into a scenario where a cure is genuinely possible. This is the outcome we are all fighting for. But that reward is earned the hard way, in the operating room. Because the post-immunotherapy field is a unique challenge. You get this significant hilar fibrosis. The tissue becomes dense, woody, desmoplastic. The consensus is that the surgical window is about 4 to 6 weeks after the last treatment. And here, your technique is everything. The 3D view and articulated instruments of a robotic platform give you a clear advantage for that precise dissection of sticky lymph nodes off the pulmonary artery. So finally, let's look at the technical toolkit, because executing these complex biology-driven surgical plans demands some seriously advanced technology to make sure it's all done safely and precisely. The move from video-assisted thoracoscopic surgery, or VATS, to robotic-assisted thoracic surgery, or RATS, has been absolutely critical. That immersive 3D view, the tremor filtration, the wristed instruments, they're not luxuries anymore. They are essential for doing these complex anatomic segmentectomies, and especially those challenging post-induction lymph node dissections. And now, the new uniportal robotic approach is promising to minimize the surgical trauma even further. And now we're pushing way beyond the limits of human vision, as you can see in this workflow. We take preoperative CT data to build a 3D model, mapping out the patient's unique anatomy for surgical planning. Then, in the OR, augmented reality can literally overlay that digital blueprint onto the surgical field, giving us real-time guidance to hit small, deep nodules with a level of precision we've never had before. And this brings us to one final thought. We've made this monumental leap from an approach dictated by anatomy to one that's driven by biology. And we've refined our skills and our tools to match it. So the real question for the next decade is this. Is the next great paradigm shift a molecular one? Are we heading toward a future with real-time feedback on tumor genetics in the operating room, guiding our hand instead of just preoperative data? That, right there, that's the frontier.